Hello, everyone. My name is Anthony Brown. I'm an investor here at Acumen America. I'm a Goldman Sachs and Manat Health Strategies alumnus who is deeply passionate about driving innovation through our healthcare system at all levels. It is an honor to kick off today's event. Thank you to everyone who joined us over the last 2 weeks for the second of our three-part series designed to help address the impact COVID-19 has had on low-income communities across the country. We've seen positive post-event activity between state Medicaid offices and a handful of health startups that have presented. And we encourage the plans and states from the last 2 weeks to continue to follow up where there are clear areas of alignment. Social isolation presented challenges and issues before COVID-19. Today, we're here to discuss social isolation in the context of COVID-19. But like we mentioned last week, we cannot discuss social isolation in the context of COVID-19 without discussing the racial realities being experienced in low-income communities. COVID-19 being wrapped into the social unrest we've seen has delivered its own set of nuances across a variety of stakeholders. The nation's most vulnerable senior citizens have effectively been relegated to the home for their own safety and may be required to stay isolated longer than other patient populations due to health risk. When most of us think about social isolation, we think about its impact on seniors, but its impact stretches much further. What is less talked about is the impact the social traumas and isolation teenagers of color in urban areas are currently experiencing. Right now, low-income students of color are doing remote learning in tough neighborhoods with less reinforcement in the home. They are losing family members to COVID-19 at higher rates than their counterparts in other races. And they are mentally battling to understand the daily protests going on and the role they should play in despite the risk of COVID-19. Social isolation is a major problem in both of these cohorts and others, and more innovation is needed to address the downstream effects of it. Despite the wide-reaching range in the type of patient populations affected by social isolation in today's America, it is unfortunate that most people still don't understand the negative impacts being isolated has on the body, our mental health, and the impacts it has on society overall. To add context to the magnitude of this problem, I wanted to highlight a few key stats and observations for seniors specifically. 1 in 4 Americans between the ages of 50 and 80 reported that they feel socially isolated, and 1 in 3 people between ages 65 to 84, and 50% of people over 85 live alone. Social isolation increases the odds of death by 26% and the odds of having a stroke by 32%. While simultaneously adding $6.7 billion annually to Medicare's medical costs. And the cost is only expected to grow naturally as our senior population rises. For communities that have experienced trauma, social isolation can also be particularly impactful relative to its downstream effects. It's also well documented how the traumas experienced by youth in low-income areas affect them in the long run. The social isolation amongst low-income youth due to COVID-19 combined with the current social unrest makes the problems even more urgent. COVID-19 has presented a unique opportunity, almost once in a generation, for plans, governments, and society overall to structurally address the long-term and short-term consequences of social isolation amongst our most vulnerable senior citizens, as well as shine a better light to the health consequences on the traumas being experienced by America's low-income youth of color pre and post COVID-19. Though this has been the last of our 3 demo days, we've been energized by the community and collaboration over the last few weeks. We hope to keep this conversation going and hope that you'll be hearing from us and know that you'll be hearing from us over the coming weeks and how we plan to stay engaged. Like I said last week, my challenge to everyone today is to commit to taking that meeting. Follow up with that entrepreneur. A win from this event would be every participant ensuring there are open lines of communication moving forward. Thank you for the time on behalf of Acumen America, the Center for Healthcare Strategies, and Adaptation Health. We look forward to hearing from our speakers and companies today to show how innovation can help solve these problems, and thank everyone in advance for their time today. Thank you.
Thanks, Tony, and thank everyone again for participating in the last event of our Demo Day series. I'm Stella Tran with Acumen America, and we'll be moderating the panel today. I'm excited to be joined by 3 great panelists: Rani Snyder from the John A. Hartford Foundation, Bruce Chernof from SCAN Foundation, and Renee Markus Hodin from Community Catalyst. And before I jump in, a few quick housekeeping items. So we will have a 30-minute panel discussion followed by the company presentations Each of the 4 companies will have about 10 minutes to present, followed by Q&A. Please feel free to pose questions via the Q&A function on Zoom to both the panelists and companies. We will also be posing questions to companies that have been provided in advance by our expert panel. And if we run out of time for Q&A, the presenters will try their best to respond to your questions over Zoom. And with that, I will now jump into the panel. So I'd like to open this panel and ask our panelists to speak to the current state of social isolation in Medicaid. Can you talk about the patient populations that have been impacted by this? And with COVID-19 and rising social isolation and feelings of loneliness, are these the same? And it'd be great to also hear what has been successful thus far in terms of payers addressing these issues. So I'll start first with you, Renee, or first with you, Bruce, then Rani, then to Renee.
Well, first, thanks to the whole team for putting together this conference. And I know on behalf of my panelists, we're really glad to be here. I just want to make some opening comments, and then my super smart panelists will actually help make sense of all this. You know, I would just observe for all of us that there's a difference between social isolation and loneliness. And so, you know, what it's going to take to build successful companies that are responsive to the population we care about. These distinctions are really important. So the point here is that you can be lonely in a crowded room. And you know, many of the kinds of aging solutions that get created with an eye towards just sort of, you know, traditionally just sort of bringing people together, the kind of you know, a senior center model. And you know, if you're not into dominoes and dancing, this sort of 1970s notion of what it means to age, that's a problem. And so you know, so my first observation is we need to be really clear and intentional about how we meet people where they are. Older adults spanned 8,000 days. It's almost a third of your life. People have different needs. And what's really, really interesting from the SCAN Foundation's perspective is that, you know, we've just completed a bunch of human-centered design work with older adults. And what's very clear is that they want the things that we all want. They just want them differently. So issues like love, vitality, friendship, and purpose are really, really important. And they are as important to the population that we care about here as any other subpopulation. So I just think we have an opportunity to really start by understanding who we're serving and what they want, and less about just what we think they need. Let me turn it over to my panelists.
Rani, why don't you go next?
Okay, Bruce, that's a great start, and I echo your thanks for this great panel on a very important topic. You know, I want to talk for just a minute about caregiver burden and support, because we're talking about social isolation in Medicaid. And for many of those who are in Medicaid already, they really rely on caregivers as the linchpin to care for those individuals. So Anthony Brown cited some statistics earlier about you know, a quarter of older adults being socially isolated, and there are over 40% of people who are over 60 who report loneliness. There are also 17 million Americans providing care for an older family member or a friend or a neighbor. And I just want to point out that that number is expected to grow exponentially in the coming decades. So whereas those issues already existed, COVID-19 exacerbates all of the things that already existed. It doesn't take anything away, but it adds complexity to the problems that caregivers face and whatever you want to call them, the beneficiary, the member, the client, the person, him or herself. And so this is a person and family-centered issue.
And I also wanted to say thanks to Tony and to Stella for having me here today. I guess I wanted to just pull out a little bit of the population that we've been talking about to speak to underserved populations. I mean, Medicaid overall, of course, can be considered an underserved population, but there are, you know, subpopulations within this. I was fortunate enough to attend last week's event on social determinants of health, and I think it's important to recognize that social isolation is also a social determinant of health. And that in general, social determinants like food, insecurity, housing, transportation, things like that, those burdens fall heavier on certain populations than on others. And so they're more prevalent among communities of color and certainly low-income populations. And so I wanted to talk just a little bit about what we know, but kind of more about what we don't know about the impact of social isolation on these populations. I did look at a recent publication. I'm sure some people who are participating today have seen this as well, from the National Academy of Sciences. They put out a report in February, and they pointed out that there's very limited research on the impact of social isolation on low-income, underserved, and vulnerable populations. That said, they pointed to a few things that, a few studies that showed that people who report feeling lonely are more likely than others to report lower income and assets and having poorer health. So I think that it's important for us to, in this conversation, and then as we think about solutions, to make sure that we're thinking about these particular communities. So I'll stop there for now.
So it sounds like there's a distinction between social isolation and loneliness. There's a higher burden on communities of color and low-income populations and their caregivers as well. So have you all seen successful payer initiatives to address some of these issues?
I'll start if I can. And one of the things that we have seen in our work, and we did a survey actually together with our partners at the SCAN Foundation, around older adults' experiences with their care since people went home to be isolated around the coronavirus issue. You know, one of the things that has been shown to be a bit of a bright spot in these times is telehealth. Clinicians can use telehealth to communicate with individuals themselves who are unable to get out, who are isolated. And it's also an opportunity to bring it back to that caregiver issue, to bring in caregivers in ways that are meaningful and that often can't happen when there are specific office or in-person visits. So that's one of the solutions, if you will, that the Centers for Medicare and Medicaid Services has opened up as a result of the pandemic.
I will absolutely second. You know, telehealth has been a real game changer, and you know, more has happened in the last 3 months than in the last 10 years. It's been really at warp speed. But I think that, and I don't mean to be the Debbie Downer here, but I think that it's important to at least acknowledge the digital divide, especially for the populations that I mentioned earlier. And for that, we know, that low-income older adults and people of color experience significant inequities in digital access. So Pew actually, I think in 2017, had a really interesting report on the digital divide among older Americans in particular, and the findings were really significant. I'll just cite a couple of the statistics. So, 81% of older Americans who had an income of 75 or above say they own smartphones. But when you talk about people who earn $30,000 a year or less, that number goes from 81% to 27%. So such a stark difference. Similarly, if you look at tablets, another tool in our telehealth toolbox, 62% of those older Americans who have incomes above 75% have tablets. And if you look at the lower rung there, it goes down to 16%. So it's, again, quite stark. And then aside from the tool itself, thinking about internet access, broadband access, we know that that's a really big challenge. Again, this is stark differences. That same Pew study talked about 94% say they go online if you're in that higher income range, and 87% have high-speed internet at home. But those go way, way down again when you're talking about people who are at the lower end of the income scale. And then I think I just wanted to make sure that we also address the differences for communities of color. Black and brown people still do not disproportionately do not have access to computer technology or to broadband. So just wanted to lift that up.
I really want to build on what you're saying, Renee, because I think it's really important for our participants. You know, I think from our foundation's perspective and our collaborations with John A. Hartford, who we do a lot of work with, but also our broader collaboration and their age-friendly health system work, which I think is really, really important. And then I think our collaborative work with our foundation colleagues around the adults with complex needs. It includes folks like Robert Wood Johnson, Peterson, oh, please help me here, Milbank, not doing so well this morning.
Commonwealth.
Commonwealth, and our newest partner,
Arnold Ventures.
the Arnold Ventures folks, which should be really interesting to this group because they take a very entrepreneurial approach to the role of philanthropy. I think, you know, it's very clear to me from a policy perspective, this is where we align really closely with Hartford, is that there's been more flexibilities offered to the entire healthcare delivery system that cares about vulnerable and older populations in the last 3 months than we've seen in the last at least 10 years. You know, and to our way of thinking, those policy flexibility, and let's be clear about what they are, so let's be a little wonkalicious for a sec. There's a bunch of flexibilities in the Medicaid program, largely in what are called 1135 waivers and an appendix of the 1915 waiver. 1135 is sort of for emergencies, and 1915 is what allows various forms of more organized care like Medicaid managed care to exist, amongst other things. And then on the Medicare side, there's all these flexibilities that are just being granted through CMS, through regulatory guidance. And there was a little bit of stuff in the CARES Act that actually promoted flexibility. So all this to say, there's all this flexibility out there, and states are trying to figure out what to do with it. They at least understand the Medicaid piece a little bit. They understand the Medicare piece a lot less. And the interaction between the two is actually really important. Part of why I raise all this, and so in terms of making our listeners sort of smarter and strategic about the businesses they're developing, the reality is when you look at those flexibilities, they fit in 3 buckets. So there's a bucket of things that exist, are really being used as a result of the flexibilities, and while they may need some they may need a haircut around the edges just to make sure that they look good going forward, they need to stay. And I think telehealth is a great example of that. You know, I'm one of those people who grew up watching medical conferences come and go about how telehealth was going to change the world, and then it never did. And so it's sort of interesting that this moment and the work that we did with John A. Hartford and AP North, our polling work that showed that 1 month to the day into the COVID crisis from the formal shutdown, 20% of all older adults had already had a telemedicine visit in a randomly selected national sample. That's pretty amazing. And you know, more than 90% of them said it was as good as or better than actually going to see the doctor. So there's something that obviously needs to stay, and the regulatory world needs to support that. You know, the second category of things, and we'll come back to them when we get to our last set of questions, there's stuff that we're like right on the face of it, but really hard to implement. So there's been a bunch of flexibilities offered to health plans around what you can do about linking to home and community-based services and, you know, trying to meet people's needs in ways that aren't sort of purely medical. And while those sound great, if you've ever worked in a health plan, for example, and being told, well, you have all these flexibilities, but you have to treat everybody equally, just like it's a medical benefit. And after the fact, we'll come back and audit you. You know, and then we'll see in the audit whether you did it right or not. I mean, that gives everybody pause because nobody wants to be told they did it wrong. And health plans don't necessarily know a lot, for example, about home and community-based services. What's that network look like? And then finally, there's a bucket of things that are frankly wrong. I'll just say, speaking only for myself, I think they're unethical in the flexibilities and they need to go away. So for example, one of the flexibilities allows nursing homes, instead of having to get a plan of care on the chart within a few days, they have up to a month. And I just think that's unethical. I mean, why should anybody be in a nursing home and not have a plan of care on the chart? So I raise all this because these two things are true, right? You're going to see all these flexibilities which create all kinds of new business opportunities to better integrate and organize care. And there's going to need to be leadership on how to do that. And so I think as you look at the world, it's worth noting kind of where those flexibilities are, how do you improve the system how do you take an opaque or somewhat, less than entirely ethical problem and make it better? States are going to be looking for that help. Plans are going to be looking for that help. And I think payers would welcome solutions that help take friction out of those areas for them.
Yeah, it's promising to see health plans engage community resources or the social determinants payments for non-emergency medical transport and food insecurity to tackle isolation. But Bruce, to your point that the flexibility can bring in issues as well. And so do you see this changing in the near future around different policy and payment levers?
I really do. And I'd be very interested to hear both my panelists weigh in on this. So having sort of laid that out, I think this creates great opportunities. And I really do think they get at areas of really rethinking what care coordination looks like, and not care in the medical, just in the pure medical sense, but really understanding what goal attainment measures and person-reported outcomes look like. I think the way you get to better care at lower costs is not just solving the medical problems, but actually sort of meeting the whole person's needs. I mean, Medicaid individuals or dual eligible individuals show up as a fully integrated human being, and then we break them down into all these little programs. Like, that's a Medicaid thing, but that's a waiver thing, but that's a food thing, and you need Meals on Wheels, and that's an energy thing. So you need the low-income energy program. I mean, I think, so that's a real opportunity around a more holistic approach to care coordination. I think there's an enormous opportunity to take friction and opacity out of how we organize and link home and community-based services providers to traditional healthcare providers. And then finally, going back to Rani's point, I just think there are needs around caregivers that are wildly unmet, and they're a huge part of the solution. And I would just end by saying, I think we have to be really careful about who we're solving for, because, in this world, starting with everybody who's listening, we all live in a kind of autonomy for me and safety for you environment. So for all of you on this webinar who have kids, like, we want our kids to be safe. Unless you happen to be a free-range parent, you want you have rules for your kids about how far they can go and where they need to be and how they check in. And I would just say, older adults don't want to be treated like your children, right? And so, when people run up to me and say, I've got a camera that we can put in the bathroom so you can see if mom's having trouble getting off the toilet, I guarantee you, mom doesn't want a camera in the bathroom. And I don't think you do either. And so I just think, as we think about helping meet caregivers where we are, their needs are different than the people they're caring for, and sort of understanding how you solve for both parts of that dyad and who's actually paying and why is really important.
I wonder if I can follow up by highlighting a specific program that exists, the PACE program, which responds to some of the both medical but also non-medical needs that Bruce was just referring to. So PACE stands for Program of All-Inclusive Care of the Elderly. And it's a program that blends Medicare and Medicaid dollars to deliver healthcare and those social services to allow nursing home eligible people to stay in their own home and community. It's been in existence for a long time, but it's been underutilized. And I think that this situation is showing us more and more how necessary some of the PACE ways of addressing the issues are. So, the aim of the PACE programs is to reduce the loneliness and increase overall socialization through a variety of functions like center-based day services, the medical care, of course. Also, PACE programs offer daily activity support, like assistance with eating and with dressing. And some of the PACE programs in this environment have been really creative in the ways that they have responded to the needs of their clients, the individuals who use PACE. So we've heard from the National PACE Association about PACE organizations, setting up a phone tree for their participants to support them staying in touch with their various friends who are in the PACE program, for example. This speaks directly to social isolation. Another PACE response during the pandemic has been to organize specific delivered daily activities for participants and their caregivers. So one of the things that's currently ongoing through the National PACE Association is actually determining various ways of expanding PACE programs. That includes making individual PACE programs larger, creating new PACE programs, and really thinking about ways to get into some of those rural areas as well that have been difficult to access. But as the federal government opens up sort of the abilities to grow PACE, there's a lot of great work out there that we'd love to see go further.
Thanks, Rani.
I would endorse that 100%. PACE is a terrific program that should be expanded. I think, beyond PACE, we need to double down on the theme of this whole part of the conversation around, team-based care, interdisciplinary approaches, medical working together with social services. I did want to, highlight, again, thinking about the population that I've returned to several times now, I think it's important for us to think about, who's doing that work and, where we as a society are putting our dollars. And one of the, best investments I think that we've seen is around community health workers, going out to people in the communities that they're already in. Really effective solution that for many reasons, but I think, to the topic of this conversation, to address social isolation. But that requires not only, some funding changes, but also making sure that we are doing enough to support those positions with that funding. So making sure that we're paying them enough, making sure that they have, good benefits. And in the COVID era, making sure that they have the personal protective equipment that they need to keep themselves safe and also keep the people that they're working with safe. They, as well as others in the healthcare system, whether it's, health plans, health providers, can do more around screening. We can require that more screening for social isolation. We can also require in Medicaid contracts, for instance, that screening, the results of that screening end up in the electronic health record, so that other providers have access to an understanding of that person's entire needs. And then lastly, I guess I would encourage, just going back on what I said earlier around the digital divide, finding ways to overcome that. And we may hear some of that today, but we're starting to see the ability, even in small community-based organizations, to get low-cost tablets into people's homes, so that they, and fully loaded, for instance, with the programs that they need, and training so that they feel supported on that. And I think there are ways that we can use our existing system, our existing flexibilities that Bruce talked about before, and our the contracting power that states have with health plans to make that happen.
Great. Thanks, everyone. Thank you all for the great insight. We will now move into our company presentations.